Professor?
Yes.
Professor? Sorry.
Yes.
Okay. Okay. I will introduce you briefly. The master today is Professor Kaj Blennow. Professor Blennow is professor and academic chair in neurochemistry at University of Gothenburg and the head of a clinical neurochemistry lab at Sahlgrenska University Hospital in Gothenburg, Sweden. He is the president of the Society for CSF Analysis and Clinical Neurochemistry, head of Alzheimer's Association Quality Control Program for CSF biomarker, and the chair of International Federation of Clinical Chemistry Working Group for CSF protein. He has received several scientific awards because of his great contribution to research of fluid biomarkers for Alzheimer's disease. Title of his talk today is Update and the Recent Advance on Blood-Based Biomarker for Alzheimer's Disease. Let's welcome Professor Blennow. Please, sorry, and welcome.
Thank you so much. Thank you for the invitation, and I'm happy to present to you today on blood biomarkers for Alzheimer's disease and what has happened the last years. Just to tell you, I have actually been in Taipei and in your beautiful country, Taiwan, a number of years ago, so I liked it a lot. But today it's online, so let's start. I work in neurochemistry with biomarker development, new assays, clinical studies, new antibodies, and that type of things. And the focus is on Alzheimer's disease. So why do we then need biomarkers for AD? So that is of course for diagnosis and to be able to monitor the pathology in patients living with the disease. And the new thing is here, that's the A-beta or anti-amyloid immunotherapies. So this has come the last years. We have now 3 antibodies that show great promise. Aducanumab, that was actually approved in the United States. Lecanemab, which comes from Sweden and was developed by Eisai in Japan. And then donanemab by Lilly. And they in phase 3 trials, they all show a distinct and dose-dependent reduction in amyloid load as evaluated by amyloid PET. And the good thing is that they also show a slowing of a cognitive decline during 1.5 years, so around 25 to 35% slowing, and they actually also show signs of downstream effects if you evaluate the cerebrospinal fluid or blood biomarkers for tau pathology, neurodegeneration, and synaptic dysfunction. There's a change towards normalization. So this of course calls for an even greater need for biomarkers for AD, and they could be used as screening tools for triaging of patients with early cognitive symptoms, and they could also be used maybe as diagnostic test for establishment of the diagnosis before initiation of treatment. So what do we then have today? This is a cartoon from a recent paper, a review on blood biomarkers for AD, and they follow the ATN schedule. So this is the amyloid and tau and neurodegeneration schedule for AD biomarkers. And then it's in principle the same as in cerebrospinal fluid. So we have A-beta, beta amyloid, 42 and 40. We have phosphorylated tau, different variants, including phospho-tau 181, 217, and 231. We have total tau that, depending on which assay is used, and I will come back to this. So some assays don't work well in blood and others work clearly better. we have neurofilament light, and we also have a glial protein called GFAP. So let's look how these work, the blood-based biomarkers. So since the concentration is so very low, we need very sensitive techniques, and one out of these techniques available that has been used very much, especially in the beginning, is SIMOA, or single molecule array. And this is a bead-based immunoassay that enables a digital quantification, meaning that you can have a real high analytical sensitivity. So it's actually up to 1,000 times more sensitive than ELISA measurements. And here you see the first study on plasma A-beta ratio, so the Alzheimer biomarker, in the Biofinder study. And there was significant but only minor decrease in plasma A-beta 42 to 40 ratio. It was around 10 to 20%. So promising, but not super good. Another technique that has been important is mass spectrometry. So this is a paper from 2014 where we set up a method to do immunoprecipitation with A-beta antibodies followed by mass spectrometry, so either LC-MS or MADI-TOF. And here you see part of the results. So at the group level, we show that it is possible to quantify A-beta in plasma using this technique, and that there is a trend for a reduction in the AD group around 10% lower, but it's quite small and there's an overlap between groups. So we were a bit disappointed with A-beta measurements using mass spec actually. But then came these studies from United States, so they had a little bit larger cohorts. They had amyloid PET to classify the patients into amyloid positive and amyloid negative, and then you can see a significant change and a quite high AUC value of, in this case, 0.88. But again, the change is not so marked. It's only around 10%, and you see the overlap between groups. The year after came this study. This was in 2018. It was a collaboration between groups in Japan and in Australia, and they also did the A-beta ratio and also another peptide called APP 6692711, which is a variant of A-beta that is 3 amino acids longer, and they even combine those two biomarkers into a composite biomarker. And then you could again see a significant change in amyloid positive AD and MCI cases, with high AUC values up to close to 0.90 actually. So promising results, but again not the too marked change and an overlap between groups. So what could then be the problem with A-beta in plasma? It came to some degree the answer in this study, also by the American group in WashU, Randy Bateman and colleagues. So here they directly compared plasma A-beta ratio with cerebrospinal fluid A-beta ratio. So plasma to the left and CSF to the right, and cases divided into PET negative and PET positive. And it's quite clear that the reduction you see in plasma is much lower. It's only around 10% down compared to 43% reduction in cerebrospinal fluid. So there is some difference, and the question is, why is this so? So you see the change at the group level, but it doesn't look like you can work use it at the individual level. So after that there came a number of different assays, so 4 different mass spec methods and 4 different immunoassays were compared in this study, including fully automated versions of assays for plasma A-beta 42 and 40, and here you see the AUC curves. So they all give rather high AUC curves to detect brain amyloidosis, meaning Alzheimer's disease, especially the IPMS method. But if you again compare to cerebrospinal fluid, where you see a 56% reduction, it's only around 10% in plasma in the same individuals again. So here is the possible explanation, I would say, that if you do a correlation between plasma and cerebrospinal fluid, this has been shown in several studies today, there's no correlation at all or really weak. And the same is true regardless of which method you use. So it could be Simoa, could be ELISA, could be Alexis assays, but there is no correlation, meaning that what you measure in plasma does not, or does only to a very minor portion, come from the brain, meaning that the plasma A-beta is not the ideal biomarker for Alzheimer's disease, in contrast then to cerebrospinal fluid, where the change is really clearer. And today the A-beta 42 to 40 ratio in CSF is actually FDA approved, and then on the Lumipulse instrument. So let's move on. Let's go to plasma Phospho-tau 181. How did this story start? Here is the first paper. So they used a Simoa assay for total. You can actually see quite a clear change. So clear increase in AD, and the good thing is that you also see a clear correlation between plasma and CSF levels. So quite promising results. This was in 2017. Here comes the next study from the year after. This was the Lilly group in US with Jeff Dage, and they developed a mesoscale MSD assay for Phospho-tau 181. They also compared to total tau. But here you see the results. So they divided again the patients into amyloid positive MCI cases and negative, and the same for cognitively unimpaired individuals, or CU. And then of course AD dementia cases, they are amyloid positive. And you see that there's a clear increase in AD and amyloid positive AD with an AUC value of 0.80. And the good thing is, as you see here, that the Phospho-tau 181 in plasma actually correlates with tau PET severity of tau pathology within the amyloid positive cases. So again, very promising data for phospho-tau in plasma as a blood biomarker for AD. And this stimulated a number of groups to develop assays. So here you see 3 of them. There are even more today. So to the left, it's our assay for Phospho-tau 181, a Simoa assay. In the middle, 217 assay, and mesoscale assay developed by Lilly, and to the right, the 231 assay, also developed here in Gothenburg. And I have put the results together because they are quite similar. These are large studies and many different diseases examined, and healthy people as controls. And in principle, the assays all show the same thing. There's a clear increase in AD dementia and also in amyloid positive MCI cases, and to some degree in amyloid positive unimpaired people. One thing that you can see is that Phospho-tau 217 has the largest fold change, so the largest degree of increase in AD dementia cases. A good thing is that plasma phospho-tau does not change in other tauopathies, for example PSP or other dementias, and also that plasma phospho-tau increases with more severe and more widespread tau pathology. So correlates with changes in the brain, which is of course very good. So how early can we go with this type of phospho-tau assays in blood? This is one example. This is phospho-tau 181, but it's the same or similar for the other assays. So here you see cases, or actually unimpaired people who have BROC 0 by a tau PET, meaning that they do not have measurable amounts of tau pathology, and some of them have a positive amyloid PET scan, and you see that in this group there's an increase at the group level of phospho-tau 181, and the AUC value is 0.85, which is quite good. So it looks like the change come rather early, already when the tau PET scan still is negative actually. And this has been verified in other studies, also in familial AD cases. So this is a study from London, or a collaboration between Gothenburg and London on FAD with symptomatic cases, asymptomatic mutation carriers, and also non-carrier family members, so controls. And here you see the data showing that the phospho-tau in blood increases already in the symptomatic state, and quite clearly with high AUC values. The mean is around 7 years before the expected year of onset, so quite early onset of symptoms, I mean then. And at the group level you can see that the lines start to separate around 16 years before the expected years of onset of symptoms. So quite early changes. Since we have different biomarkers and different assays, then there came a discussion on whether they are different. So are the assays different, or are the biomarkers different? So this is a study again by the Lilly group together with Adam Box's team in San Francisco. So they studied a cohort with AD and FTD spectrum cases and healthy people assessed by both amyloid PET and tau PET. And the thing is that they developed two MSD methods that were in principle the same, except for the antibody used, meaning that one could react with phospho-tau 181 and the other only with phospho-tau 217. So this is to study the biomarker and not the differences across assays. And here you see the results. So the concordance or association with amyloid PET was very similar and good. So 217 to the right and 181 in blue. I'm sorry, to the left you have 217. And AUC values are high, around 0.90. And then you have tau PET data, also very similar and very good performance. So in principle the same results, you could say, but the difference is that the fold change, so the degree of increase in AD dementia cases is higher for phospho-tau 217 than for phospho-tau 181. And this has been verified in several studies, you could say. This is a study with even more detailed comparison, and here you have all three biomarkers, so 181, 217 and 231 in the alpha plus cohort from Barcelona, and they compared the change in different stages of amyloid pathology, And as you see here, the change for phospho-tau 231 comes with lower amounts of amyloid pathology, so it's 26 centiloids compared to 35 for phospho-tau 217. So according to this study, plasma phospho-tau 231 seems to be earlier than 217, but both perform quite well to detect A-beta plaque pathology. This is still a study comparing the three biomarkers. This is in BioFinder study with Oskar Hansson and colleagues. And here you also have longitudinal data. So here you see first the associations with amyloid PET. So to the left you have phospho-tau 231. And the main finding here is that the change comes earlier again for 231 as compared to 217 and 181. And here you see the longitudinal data instead. So here it's clear that with time, when you come to the AD dementia stage, then the change is larger for phospho-tau 217 than for 231 and 181. So here you see the summary. So in principle you could say that phospho-tau 231 seems to be the earliest phospho-tau biomarker that is more responsive to minor amyloid pathology, while phospho-tau 217 seems to better track disease progression with a higher fold change with severe disease. Then of course you have other types of techniques, and I will show you one of these methods, and this is a method called immunomagnetic reduction, or IMR, that was developed by the MagQ company at Taiwan. So this is a study on healthy people and then MCI due to AD and then very mild AD dementia, and you have a phospho-tau levels in blood or plasma here, and as you can see there's a quite clear increase in both MCI and mild AD, and here you see the AUC curves, which are quite good. So 0.86 for the MCI stage and 0.78 for the mild AD group. So very promising results for plasma phospho-tau 181 by IMR as an AD blood biomarker. So how about non-phospho-tau or total tau in blood? So if you use Simoa with two antibodies, it doesn't look that good, just like for A-beta maybe. So here is data from the ADNI. There is a slight, very minor increase, and the overlap is large between AD patients and MCI and controls. And then you see to the right that there's a very poor, or in principle absent, correlation between plasma and CSF levels of total tau by Simoa. So how can this be? This is most likely because you also have a peripheral form of phospho-tau called big tau, and this variant has an insert, so it's a larger protein, and thus it's called big tau. It's from exon 4A. And the antibodies used in Simoas, they are located in the region that doesn't differ between brain-derived tau or CNS tau and the peripheral form of tau. And the same is true actually if you use these antibodies to capture tau in blood and then do mass spec. You will measure a mixture of CNS tau and peripherally produced tau. But if you then instead have an antibody that you have produced against this junction between exons 4 and 5, so it needs both these sections or domains of tau, then it cannot react with peripherally produced tau, And we produced such an antibody. This was published last year in Brain Journal. And suddenly you can see a change in AD, so there's a clear increase in AD compared to non-AD dementias and controls. It's around double the amount. The same is true if you go to a neuropathologically confirmed cohort. This is from UCSD with Doc Glasgow. So concentration is about twice as high in those with AD-type pathology compared to those with low pathology or other pathology. This is, of course, samples taken during life and then follow-up examination at neuropathology. And then this is interesting because this is rapidly progressing dementias. So rapidly progressing AD and then CJD, Creutzfeldt-Jakob disease. And there you see an even more marked change in brain-derived tau. So it looks like BD-tau is clearly higher in rapidly progressing dementias, meaning that it reflects the intensity of neurodegeneration, even if you measure it in plasma samples. So this is very similar to the information that you can get from total tau if you go to cerebrospinal fluid. So do we have more biomarkers? Yes, one is neurofilament light, or NFL. So this is also an axonal protein. It's present in the long myelinated axon, and it's released to the cerebrospinal fluid and blood when you have axonal degeneration and also acute axonal damage. And this is from 2015. We developed a Simoa method to measure NFL in blood, and the good thing is that this was, and this has been verified in many different papers, a very tight correlation between plasma and CSF levels of NFL, so actually close to 0.90, which is very good, supporting that plasma NFL measurements reflects neurodegeneration in the brain. So let's look at Alzheimer's disease. This is from the ADNI study in the US, and here you can see actually that plasma NFL has the same or very similar AUC value to identify AD as cerebrospinal fluid NFL, and also similar to, for example, total tau. Another thing is that higher NFL levels in plasma predicts future rate of cognitive change, so more severe cognitive deterioration with higher NFL levels in blood. How early can we go with plasma NFL in AD then? This is from the Diane study. This is FAD mutation carriers and non-carriers. So you see cerebrospinal fluid NFL to the left and plasma or serum NFL to the right. And they look quite similar. It's a little bit more overlap in plasma than in CSF. But it's clear that NFL show promise as an early screening test for neurodegeneration, and in this study it was positive around 7 years before the expected years of onset of symptoms in FAD. So we also have other types of assay. This is again immunomagnetic reduction assay for NFL. And here you will see a cohort with AD cases with Parkinson's disease and PDD, meaning PD dementia, and then healthy controls, assessed then plasma NFL. And here you see the data. So there's a clear increase both in PD-PDD and in AD using this assay. And here you see the AUC values. So they are quite high to differentiate PD and PDD and AD from controls. So AUC values are in the range of 0.84 up to 0.92. So quite promising. supporting that plasma NFL by IMR have a high performance to identify these diseases. But one thing to keep in mind, and this accounts for all assays for NFL, so regardless of technology, this is the biomarker in itself, that NFL is high in many different brain disorders. It's not specific for a certain disease, so it's not only high in AD, it's also high in for example FTD and ALS and some others, for example PSP and CBD. It's used in multiple sclerosis to monitor treatment, and it's has been assessed in stroke to monitor the severity of a stroke and so forth. So it's a very sensitive but at the same time disease unspecific biomarker for axonal injury and axonal degeneration. How about the GFAP? This is the glial protein. This is a study based on Simoa and the several different cohorts. Here you see the triad cohort from Montreal and then a clinical cohort from Paris. And it's clear that there is an increase in GFAP in plasma with amyloid type pathology or AD pathology. So it seems to come quite early, already in the MCI stage and even in amyloid positive unimpaired people. So this has been found similar data in other studies than this, and supporting that plasma GFAP is a sensitive biomarker associated with glial activation and early brain amyloidosis in AD. So then, can we combine different biomarkers? This is a study using Alexis assays. So two different cohorts, quite large, and then Alexis assays for plasma A-beta, Phospho-tau 181, 217, and then also NFL and GFAP and APOE4. So here you see part of the data, both in the panel A study, which is a clinical cohort, and the biofinder study. You can see that the combination of different biomarkers work quite well. So you have AUC values up to 0.93. Actually, also with this type of fully automated assays, and in another study on the ABEL cohort, also quite large, if you only used the Phospho-tau 181 and APOE, you could end up with a AUC of 0.92. And the reason for this study with ABEL was that it was ascertained that plasma A-beta have a very low robustness for clinical routine use, so this assay wasn't actually continued. But we need to evaluate which combination would work the best further in research studies. And this is again another technique. This is the IMR method on the MAC-Q instruments. So this is a cohort with AD, so both MCI and dementia cases, PD and PD dementia, FTD, and then healthy controls, and then IMR assays for beta amyloid, for alpha-synuclein it should be, so alpha-syn and TDP43. And here you see the results. So there are quite clear changes. So for example, TDP43 is high in FTD, alpha-synuclein is high in Parkinson's disease, and A-beta 40 and total tau are changed in AD. So this is if you look at the dominant biomarker in these different disease categories. So for AD is beta amyloid and total tau. For Parkinson's disease and PDD, it's alpha-synuclein as expected, and for FTD it's TDP43. So it looks like a combination of these biomarkers using IMR assays on plasma have a high potential to be used as biomarkers to discriminate these disorders actually. So this is just a more principled discussion on how you can use biomarkers in the future. This is focused on plasma Phospho-tau 217 and two different cohorts, Biofinder 1 and Biofinder 2, to assess a logistic regression model for the combination of 217, Phospho-tau, age and APOE4. And that worked quite good, and you could end up with sensitivity and specificity figures like this. You see here, so AUC values, which is a little bit different, but AUCs are not really used in clinical routine or in clinical chemistry. There we use sensitivity and specificity instead, and then false positives and negatives. So the question is, if you use this type of single cutoff, then you will end up with a rate of 15 to 20% false positives and negatives. And the question is this acceptable, for example, to start up with treatments with A-beta immunotherapies? I don't think so. So we worked further on a two-step model where we had two different cutoffs, one cutoff to identify a high probability group, meaning high probability for brain amyloidosis, and another cutoff for a low risk group. And you can see that the performance is quite good here. And then you always have an intermediate group where you need to do something more, which could be a CSF test or a PET scan. But the good thing with this two-step approach is that there is a reduction of a needed CSF or PET test from around 60 to 85%, depending on how you set your cutoff and how you want your sensitivities and specificities. So maybe in the future we can do something like this, that we have patients with cognitive symptoms. You apply this type of models. It could be Phospho-tau, it could be other combinations, it could be different techniques, for example Alexis or Lumipulse assays or IMR assays, and then you do the risk stratification into high probability for having AD. In some cases you could make a diagnosis. In other cases maybe you need to send them into the specialist clinic. You will always have an intermediate group, maybe up to 20-30% of cases where you need to do a CSF or a PET scan, and then you have a low probability group where you know it's not AD, and in some cases maybe you need to do other type of tests such as CT scans or MRI scans or psychiatric assessments and so on. Maybe this is the way to do it in the future, and maybe we can also use this type of tests to monitor treatments, because in these trials, the phase 3 trials from the anti-amyloid immunotherapies, it was clear that there was a reduction in plasma Phospho-tau levels quite early and then going further down, both for lecanemab and for donanemab. And maybe this is a way to monitor treatments in the future. One thing to note for donanemab was that the drop was not down to normal levels, so you start quite high, around maybe a 400% increase, and then levels dropped down to 23% from baseline levels, so far from normalization. And we need to understand then in routine clinical application if continued treatment will take plasma phospho-tau or other biomarkers down to normal levels, and if you discontinue a treatment whether phospho-tau will creep back up. But I think we can use this type of blood biomarkers also to monitor A-beta immunotherapies, so I think blood-based biomarkers is a very important step forward in the management of patients with suspected AD. Thank you so much for listening, and I'm happy to take questions.
Thank you, Professor Blennow. A wonderful talk, especially you mentioned about the brain-derived tau.
Yeah.
Okay. Yeah. Okay. Professor Blennows' talk is open for questions. Any comment or questions from our audience? I have one question. The brain-derived tau, does it include the p-tau?
That's an interesting question, and we need to assess that further, and it looks like the very large majority of what you capture is actually not phosphorylated. So it's a little bit like phospho-tau in blood seems to come primarily from the brain, in contrast to non-phosphorylated tau, and that's why you need the BD-tau assay to measure tau in the periphery, but not phospho-tau then.
Okay, thank you. Do you have any experience about the biological dementia?
I'm sorry, please say.
I mean the dementia due to the stroke, cerebrovascular disease.
Aha.
Yeah.
That hasn't been so well examined, and I don't think there are any really promising biomarkers today, because I mean what I showed you was that we have promising biomarkers for AD. We also have, based on the technique, for example, IMR looks promising for Parkinson's disease and also for FTD, but for cerebrovascular disease or more chronic cognitive changes after stroke, we don't have that good biomarkers. That is an important research field, I think.
Okay, thank you. Please raise your questions, our audience. Or Dr. Huang or Dr. Li, any questions?
Yes, I have a question. I'm Dr. Li from Taichung. Thank you, Professor Blennow. I have a question about the clinical difference between the plasma GFAP and the phospho-tau, because we know that these two kind of biomarkers may reflect the neurodegeneration severity in the brain. So, what's your opinion about the difference between the two different kind of biomarkers?
I mean, first of all, they are clearly different because they are different proteins and different assays and so on. But as you say, they perform quite similarly. So I think we need to study that further as well. So, I mean, a good example of a similar situation, I think, is early days when you had total tau and phospho-tau in cerebrospinal fluid, and we know that there's a very tight correlation between these biomarkers, and then people started to question whether we need both or not. But I think when this biomarker started to be tested in clinical practice, then you could see that and also as published at that time in research studies, that if you have disorders, for example, like Creutzfeldt-Jakob disease or encephalitis or stroke or brain trauma, then you had a change in total tau, but not in phospho-tau. But in AD, it's different because there both are changed. So maybe this is the way to understand more on GFAP and phospho-tau as well, that you need to examine them in other brain disorders to see if you can identify conditions where there's a change in phospho-tau but not in GFAP, for example. But I agree also that a hypothesis or a possibility is maybe that the release mechanism for both is similar, so that, for example, if you have some variant of blood-brain barrier damage or opening, then you will have a release of both GFAP and phospho-tau. But as I think we need to understand that in more detail through research. But it's an interesting and important question. Thank you.
Yeah, thank you. And I'm going to follow this question. And because we see the recent study showed the phospho-tau level is highly associated with the amyloid pathology. And do you think that GFAP do the same way?
Yeah, it looks like that. But then we have to remember that this is only associations. So I mean, you have higher phospho-tau with more brain amyloidosis, and you have higher GFAP in the same way, but still it's not a direct link. It's only associations based on different assessments. So in this case, PET scans and blood biomarkers. So yeah, we'll see. But they are clearly related to AD type pathology, that's for sure.
Yeah, thank you.
Mike, I have another question. There are a lot of major tools to measure the blood-based biomarkers. Which one do you recommend, or what should we consider how to choose one?
You mean techniques?
Yeah, we have a Shimoa, we have a IMR, we have a lot of tools to measure the biomarkers. Which one? Yeah, we have to choose one.
So I'm sorry, but I wouldn't choose one. I think each laboratory has to choose their platform. I don't think we have enough studies to say that one is better than the other. I mean, if you go to the US, then there's a lot of pushing for mass spectrometry, that this should be better, but then if you look at other studies, it's quite similar to the immunoassays actually. So I think you should choose a platform where you have much data that you are acquainted with and you know how to use it and that it's established in your lab. But I would not like to choose a single one. Sorry.
Okay. There is a question from Dr. Chen Guanfei. Do you think exosome has the potential to be a good biomarker for AD?
Yeah, I think that's a very interesting approach. I don't think we have enough data. So far, there are a number of studies suggesting that you have actually higher levels in exosomes. So I think it needs further study. Of course, it will be a little bit more, or quite a bit maybe more complicated pre-analytical procedure before you can actually do the immunoassay if you should measure A-beta or tau or other biomarkers in exosomes, but it's definitely worth to study more to see what this type of particles can give, or if they perform better than only plasma.
Okay, thank you. Yeah. For the clinical practice, the blood-based biomarker seems like a screening tool to stratify the risk of AD. In the future, do you think a blood-based biomarker can be a diagnosis tool?
To be honest, as it looks now, I don't think so. I think a very good and important application could be screening tools. I mean, even if we could screen out, let's say 40-50% of individuals that seek medical advice, that would be very helpful, because then we don't need to do so much more on these, like PET scans or CSF taps or expensive investigations. So it would be very helpful to have this type of screening tools, I think. And as I tried to say, I also think that in some cases, maybe selected cases where you have a clinical picture that is very indicative of AD, so it's in principle, is this mild AD or is it just aging? And then you have a positive blood biomarkers, maybe you could set the diagnosis directly there in a proportion of cases, if you don't have any clear suspicion of other diseases. So we have to learn more. I think it will become more clear when we really start to get data from clinical routine also on these biomarkers, because so far it's in principle only research studies where you have like all samples are analyzed at one time, you have all the data in hand, you identify the best cutoff, and then you present the AUCs or the sensitivity and specificity figures. And I think we need also data of the same type from clinical routine, where you also run the assays day by day or week by week, and where you have a more diverse population of patients.
Okay, thank you. Is there any questions? Dr. Huang? Li Kai, do you have any questions? Maybe it's it should be the last one.
抱歉，因为我刚刚只有听到一小部分，所以还没有办法提问题。I'm sorry, I don't have a question right now. Thank you.
Okay, thank you. Yeah, because we have run out of the time, so we thank Professor Blennow again for his wonderful talk, and we hope you can visit Taiwan in the near future.
Yeah, me too. Okay. Great. Thank you so much.
Okay, I close this talk here. Thank you again. Bye-bye.
Bye-bye.
Bye-bye.